doesn't just have an impact on the nighttime blood pressure, but also on the daytime blood pressure. Now, I wanted you to pay attention a little bit to this graph here, where it shows the CPAP use, hours of CPAP use per night or per day, and then the decrease in blood pressure in relation to the hours of CPAP use. And I think that's something we talk a lot about in clinic, of how important it is to really wear your CPAP, and the insurance ones at least 4 hours. But the interesting part here is that there seems to be almost a dose effect relationship, where if you don't use your CPAP 2 hours or less, there's really no difference, or maybe, I don't know that we can say that there's harm, but your blood pressure definitely doesn't change even at the 2-hour mark. At the 3-hour mark, maybe a minimal effect. But then as you get into the longer hours of usage per night here, so 5, 6, 7, 8, which is more or less all night, you get a pretty good effect here. So this is almost a -10 decrease in blood pressure. That is more effective than a lot of the blood pressure medications were in clinical trials. But it does matter, not just that you do get a CPAP, but also how many hours per night you wear it. All right, moving on from hypertension to atrial fibrillation. Here I wanted to talk a little bit about proposed mechanisms. Why, besides the stress and maybe the increases in heart rate, what else can cause atrial fibrillation in sleep apnea, or might predispose someone? One of the theories is that when you're trying to breathe in against the closed airway, you have high intrathoracic pressure fluctuations. And so every time you're trying to breathe in, and you create a lot of negative pressure in your chest, and that stretches the heart tissue. And just the stretch and release is thought to be traumatic to the tissue. And in animal models, you can actually see here in the lower panel how without sleep apnea, there's normal heart tissue, but then with sleep apnea, there's replacement of the right atrial and left atrial tissue in this case, because of the tissue injury that can happen with sleep apnea. In addition to that, in humans with sleep apnea, there is atrial enlargement, and both of these things, the fibrosis in the atria and the enlargement, are risk factors for atrial fibrillation. This, I think, I like this study a lot. This is an atrial mapping studies in patients with sleep apnea compared to those without. These were patients that were undergoing a first-time ablation study for atrial fibrillation. There were 20 that had an HI greater than 15 compared to 20 that had an HI below 15. They excluded a number of other heart conditions like heart failure, prior heart attacks, and untreated hypertension, and so forth. They're matched by age and BMI. And what you can see here, so this is one example, right, of one of these patients with sleep apnea, one of the patients without sleep apnea. What you see in the sleep apnea group is that they have larger atria, both the left and the right atria are enlarged. They have decreased voltage in the left and right are atria, and this is the color coding here, shows you the voltage, where higher voltage is blue or purple, so you see more blue or purple in the healthy person here. And then lower voltage is red and yellow, which is you see more commonly here in this person with sleep apnea. The mean conduction velocity is lower in the atria in patients with sleep apnea. The sinus node takes a longer time to recover there's a greater number and duration of conduction abnormalities. So every one of these little points here is abnormal conduction. And there's a greater number of abnormalities at the crista terminalis, which normally is the barrier for the reentry circuit. And in addition to that, there are more areas of electrical silence, which is here this gray area in this patient with sleep apnea, where normally you would have the signal propagated, but in this patient, there's just electrical silence in this critical part of the atria. In terms of prevalence, atrial fibrillation in the general population, about 1% of adults have it. In adults with sleep apnea, that number is 5%, so 5 times higher. The reverse is also true. If you think about patients with sleep apnea, they have a much higher risk of having atrial fibrillation. So it works in both directions, right? If you have atrial fibrillation, you're more likely to have sleep apnea. If you have sleep apnea, you're more likely to have atrial fibrillation. If you look at it cross-sectional, 2 of them go together. But what I think is more interesting almost for our cardiologists that refer patients to us is the risk of recurrent atrial fibrillation in untreated sleep apnea. So here you have a comparison of different methods. You have recurrent atrial fibrillation after pulmonary vein isolation. In patients that just have atrial fibrillation without sleep apnea, the risk of recurrence is 25%. Patients with sleep apnea and atrial fibrillation, that risk is 33%. For cardioversion, these numbers are 53% with just atrial fibrillation, and then 83% in sleep apnea plus atrial fibrillation. And then for antiarrhythmic drugs, it's almost double, 39% to 70%. And that really, you start to wonder whether or not treatment of sleep apnea can bring this risk of recurrence, for example, here from 83 to 53% or not. In other words, does sleep apnea treatment prevent the recurrence of atrial fibrillation after a procedure? And there were a lot of studies that suggested that maybe there is something to that. These are all observational studies, so retrospective, sometimes prospective case-controlled studies with variable number of participants between 32 and 640. A follow-up that was also quite variable from 6-7 months to 42 months. And then in the last column here, you can see the relative risk of atrial fibrillation recurrence. And a relative risk of 1 means that the CPAP users have the exact same risk of recurrence as the CPAP non-users. A risk greater than 1 means CPAP makes it worse, higher risk of recurrence. A relative risk below 1 means CPAP helps. So your risk of recurrence is lower when you use CPAP. And then this in the second line here of each of these studies, you can see the confidence interval. And when this does not cross the number 1, then it means it is statistically significant. So you can see how in all of these observational studies, CPAP reduced the risk of atrial fibrillation recurrence by as much as 30 to 40%, pretty consistently. And that for 4 out of 5 studies, this difference was statistically significant. Now, there's also biases that go into these observational studies, right? Because people that use their CPAP might be different from those who don't use CPAP in other ways, right? Whether that be social, economical factors, generally being more compliant with medical recommendations, or whatever other reasons you might find for why these groups are different. So gold standard are still randomized controlled trials. And here are two of them that looked at the atrial fibrillation recurrence after ablations and CPAP versus non-CPAP users. But this time they were randomly assigned to either CPAP or no CPAP. The first study had 25 patients, the second one 83. Follow-up was 1 year for both of them. And you can see how here's really no difference at all between these two groups. The caveat with these studies is that both of them fell short of their declared goals. So when they designed these studies, they did a power calculation to see how many patients do we actually need in order to be able to detect the difference between these groups. The first study here, they counted that they would need to enroll 180 patients to have a 90% chance of detecting a difference between the groups. The second study, they said they needed 100 patients to have an 80% chance of detecting a difference, assuming that CPAP decreases the risk of recurrent atrial fibrillation by more than 50%. Both of these studies went through an enormous effort. If you look at this first one in particular, they screened almost 2,000 patients. They enrolled 25, and after 1 year of follow-up, there were still 9 patients in this trial. They also did not have an objective measure of CPAP adherence. So I think the conclusions for that study are very limited. We know that there's almost no chance that they would have detected a difference, even if it was there. And we're not sure whether the CPAP group, they were actually using their CPAP or not, because that was not recorded. That's not to criticize the group. That's an excellent group that performed this study. They went through years and years of work. They have a lot of experience, just to illustrate how difficult it can be to obtain good data, because the conclusion from this study was, well, we did not see any evidence that CPAP makes a difference. And that is technically true. However, there is a lot of limitations, right? In this other study, Hunt et al., again, they would have liked to enroll 100 patients. They screened 600, enrolled 83. They did have an objective measure of PAP adherence, which was 4 hours. Is that sufficient? I'm not sure. I think with the hypertension data earlier, it was right around 4 hours where maybe you saw a little bit of an effect. Here they had assumed that they have to have at least a 50% reduction in recurrence risk to be able to detect that with 100 people enrolled. So again, the conclusion was we do not see evidence that there was a difference between the groups, but keep in mind, the study was probably quite significantly underpowered, both in terms of CPAP adherence and then also a number of people that actually completed this.
I don't know if something was said or shown behind me. I'm not sure, but sorry. Sorry, back to you. The whiteboard. It's the whiteboard.
Thank you. All right. So this just shows you the differences between these study designs, how it's striking sometimes. And randomized controlled trials are still our gold standard. However, you do need to look at the actual fine print sometimes to see what did they set out to do and what were they actually able to complete in terms of the trial. Okay, moving on to coronary artery disease. This is a nice little study that was conducted a few years ago now at Mount Sinai, which is to show that actually with sleep apnea, there's atherosclerosis, we know that, but also that maybe it's reversible with CPAP. So these are only 5 patients with sleep apnea. Mean age I was 33. Everybody underwent a PET MRI to visualize their carotid arteries and their aortas. Then they were treated with CPAP for 3 to 6 months. And then they had another PET MRI to look at the plaque activity measured by FDG uptake. And then plaque activity, decreased activity just means that you're less likely to have an unstable plaque because this uptake reflects inflammatory activity and really is a measure of macrophage burden in the vessels. So it's a useful diagnostic tool to identify patients who are at risk for cardiovascular complications. Now here on the top 2 panels here, this is before CPAP treatment. You have the right carotid, the left carotid, and then on the right side, the aorta. Purple means low uptake. Red and pink means lots of uptake. And if you compare these carotids here on the right side and on the left side, before CPAP treatment to after CPAP treatment, you can see how there's more purple, I'll say, than blue. So meaning lower uptake, meaning a decrease in inflammation in these carotids. And then here in the aorta, similarly, before CPAP, you see some red here, which means lots of activity. After CPAP, there's decreased uptake, meaning decreased inflammatory activity in the aorta. Now, how does that actually correlate with sleep apnea as a risk for stroke and death, or stroke meaning, in that case, if it's embolic, maybe a plaque rupture? This was maybe one of the landmark studies that was published in 2005 in the New England Journal, and that showed among over 1,000 patients at Yale, 700 had sleep apnea, on average severe sleep apnea, an HI 4% of 35. They were followed for 3.5 years, and they showed that sleep apnea was associated with an increased risk of stroke or death. And the risk of stroke or death was really double in the sleep apnea group compared to those without sleep apnea. And also here, there was almost a linear relationship between the severity of sleep apnea and the endpoint, meaning stroke or death. Now, again, similar to the theme of this talk, you have an increased risk for sleep apnea. Does treating your sleep apnea help or decrease that risk? This is a SAVE trial that came out about 10 years after this first study. This is a randomized control trial where 2,700 patients with cardiovascular disease and sleep apnea, defined as an ODI greater than 12, were randomized either to CPAP or medical care. And then they were followed for also about 3.5 years. The primary outcome here was a composite of cardiovascular disease outcomes, meaning heart attacks, unstable coronary artery disease, TIA, strokes, heart failure, or death from cardiovascular causes. And here, there was no difference between the 2 groups. CPAP or medical care without CPAP, the risk of these composite outcomes was similar in both groups. This hazard ratio here was close to 1, and the confidence interval includes the number 1, meaning it was not statistically significant. Now, they did do a subgroup analysis of patients in the CPAP group that were actually adherent and compared them with the rest. And they found that CPAP adherence, there is some benefit in terms of cardiovascular outcomes in this group. In terms of the primary outcome, there was a trend with a hazard ratio of 0.8, so 20% risk reduction. That was not statistically significant, but maybe a trend with a p-value of 0.1. There was a risk reduction that was statistically significant in terms of risk of stroke or TIA, where there's almost a 50% reduction in those that were CPAP adherents. But as mentioned earlier, there might be lots of other confounders in these patients that explain why they were adherent and why they have a lower risk. Maybe there's something that tracks together and explains both. So you might imagine that the sleep world was disappointed at this outcome. Everybody had hoped that you would be able to demonstrate a benefit in the primary outcome. And that, led to a lot of scrutiny, justified scrutiny of this trial. And people were asking, can we actually generalize these results? One of the criticism or maybe a limiting factor when you're trying to draw conclusions is that 2/3 of the patients came from China, and the rest were Australian, whereas a lot of the epidemiological data that links sleep apnea to strokes and heart attacks and death is conducted in the US or in Europe. So there are some thoughts that maybe there are some racial, ethnic differences between the groups that could explain these findings. These patients were also relatively skinny compared to our average BMI. Here it was 29. I venture to say in our clinic it's probably above 30. They excluded patients that were really sleepy for ethical reasons. But maybe those who are the sleepiest are also the ones that would benefit the most from CPAP. And maybe the ones that are sleepy are also more likely to use their CPAP, because in this trial, the average use was only just over 3 hours per night, which, similar to what we've seen before, if you think that there might be a dose effect of CPAP, maybe 3 hours is not enough. Maybe you needed more to be able to detect a benefit from CPAP use on average. And some researchers have said that maybe this study just shows that if you're not using your CPAP, it's not helping you. Whether it would help you when you use it more, we can't draw that conclusion from that study either. Did want to spend a little bit of time talking about another disorder, and that is heart failure, and to discuss 2 trials, one of them that has caused a lot of discussion in the field of sleep medicine, and one that came out fairly recently. And I think for fellows, this is really important to know for your own practice, to know these studies. And I'm sure when you go to the sleep meeting in June, you will hear plenty of discussion of this topic, so this can serve as a primer. So heart failure is very common, as you all know. Sleep apnea and heart failure is very common, and the treatment is quite controversial. Now, heart failure alone has a pretty high mortality, despite the medications that are available. But in those patients that have sleep apnea plus heart failure, the mortality is even higher. So these are patients that have, with heart failure, everybody in this cohort had heart failure. Some of them do not have sleep apnea. Some have predominantly obstructive sleep apnea, and some have predominantly central sleep apnea. And here the follow-up, I think, was about 5 years. And if you had heart failure and obstructive sleep apnea, the risk of death was 4 times higher compared to those without sleep apnea. If you had central sleep apnea, your risk of death was almost 8 times higher compared to those without sleep apnea. I think that is an interesting observation, and it's only been recently that the subgroup of patients with heart failure and obstructive sleep apnea has gathered more attention. And there's more interest in really understanding how these two groups might be different. I think the conventional thought is that heart failure is associated with central sleep apnea, and that is true. Central sleep apnea is more common in heart failure than in the general sleep clinic population, but it is especially more common in patients that have heart failure with a reduced ejection fraction. So if you compare these two groups here of obstructive or central sleep apnea, compared to no sleep apnea, there are more men. This overall, there was a VA cohort. I think that partially explains why there's so many more men in this group. But there's even more men in these sleep apnea groups. The ones with central sleep apnea are more likely to have heart failure with reduced ejection fraction, whereas obstructive sleep apnea is more common than central sleep apnea in heart failure with preserved ejection fraction. And in general, these patients here that have obstructive sleep apnea, they tend to look more like our typical sleep clinic obstructive sleep apnea patients in that their BMI tends to be high, they tend to have excessive daytime sleepiness, and they snore. Whereas this group here, the ones that have central sleep apnea, they are not necessarily overweight, and they tend to have more complaints of insomnia or fatigue, but not really snoring, not really sleep quality issues in terms of daytime symptoms. I think we see both in our clinic, but I'm sure all fellows have seen this patient referred from cardiology that really doesn't have a lot of complaints and really doesn't sound like your typical sleep apnea patient in clinic, and yet their sleep study shows that they do have it. Now, what happens if you treat it, especially this group here, right, with central sleep apnea and this high risk of death? Does treatment of central sleep apnea help these patients? And here I want to focus on two studies that used ASV for central sleep apnea in heart failure, in this case, heart failure with reduced ejection fraction. The study here published in 2015, the SERVE heart failure trial has gathered a lot of attention because of its unexpected results and important implications for our patient care. So they recruited 1,300 patients with a left ventricular ejection fraction equal or lower than 45%, an AHI greater than 15, and more than 50% of the respiratory events had to be central. The primary endpoint were death or life-saving cardiovascular interventions, so things like CPR or defibrillation that was used appropriately and so forth, or heart failure hospitalization. They used ResMeds machines to treat with ASV and compared that to medical treatment alone without ASV. There was no difference in the primary endpoint in this composite outcome. However, in the ASV group, and I think this was the unexpected finding, there was an increased all-cause mortality with a hazard ratio of 1.3, and also an increased cardiovascular mortality with, again, a hazard ratio of 1.3. Mostly this was all driven by sudden cardiac death. And following the study, the ASM put out a safety notice saying that in symptomatic, or in general, in heart failure, later on modified to symptomatic heart failure with ejection fraction of 45 or below, ASV is contraindicated. And I think that's how we've counseled our patients over the last couple of years. based on the results of this trial, because there was the signal that treating your central sleep apnea might actually make things worse. And maybe some people have hypothesized there is actually a protective effect of these central apneas that help the heart survive longer. Now, earlier this year, a second study was published, the Advent Heart Failure Trial. This was, again, a multi-center, open-label, phase 3 randomized controlled trial. They enrolled 731 patients with a left ventricular ejection fraction lower than 45% or equal to 45%, HI greater than 15. In this trial, they allowed either central sleep apnea or obstructive sleep apnea, arguing that both are very common and a lot of patients have both central events and obstructive events, and you should treat both. But they excluded patients with predominantly obstructive sleep apnea that were sleepy. Primary endpoint were death, cardiovascular hospitalizations, incident atrial fibrillation, or an appropriate ICD shock. They used Philips devices compared to medical treatment alone. They encountered a lot of challenges. This study started in 2010 and ended in 2021. So you get the idea that between then and now, there was the SERVE heart failure trial came out, the one that we just talked about, that had a signal of increased mortality with ASV. So they did an interim analysis, made sure that this is not the case in this cohort, and then they were given the green light to continue. Then COVID came around and put a lot of difficulties because in-person follow-ups were impossible, follow-up sleep studies were impossible. And then the Philips recall came, right? And they couldn't continue to use these ASV machines because they were recalled. So in 2021, they ended this trial. Their initial goal was 860 patients for 80% power. Here they had 731, and in the end did not find a difference in terms of primary endpoint or all-cause mortality. Yeah, so what to make of that? I'm actually curious to hear what others in the room think, and whether this has changed their practice or this has changed how they counsel patients when it comes to treatment of sleep apnea and heart failure with reduced ejection fraction. But maybe we can keep that discussion for the end. So I think, talking about these randomized control trials, which are considered the gold standard, I might have given you a sense of how difficult it is to perform good trials. We can design them and have power calculations, but the reality is often very difficult. You remember the one study that I showed where they had to screen 2,000 patients to get 25 into their study when they were aiming for 200 almost. And this is still relatively modest sample sizes because in cardiology, a lot of the trials have 20,000 or more participants. So cardiology is often able to detect much smaller changes between groups. With these sample sizes that the sleep world is operating with, you would have to have really rather large effects of CPAP to be able to detect them. Some criticism is along the patient selection. Sometimes severe sleep apnea is excluded. Daytime sleepiness can be excluded for ethical reasons because you can't randomize a patient that is excessively sleepy, at risk for car accidents and so forth. But that might also limit your study in some degree. Maybe those who are most symptomatic would actually also benefit the most. Some people have suggested to treat sleepiness with wake-promoting agents to help those that are not randomized to CPAP. I think that's very controversial. Is that ethical or not? Other options would be to increase the sample size, and either increase the trial duration or increase the sample size even further to decrease the trial duration, just so that you capture more event and you're more likely to detect a difference between groups. People have tried to improve CPAP adherence in these trials because, like I said earlier, if you're not using your CPAP, it's not going to help you. And there have been efforts to have a longer run-in period and only randomize people that can actually tolerate CPAP, so that on average you get a higher adherence rate and you don't have that limitation that your average use is only 3 hours a night. There could be interventions during the trial as well to improve adherence. Some people have suggested that maybe it's time to analyze these studies differently. For heart failure in particular, there's a lot of interest in pharmacological trials, things like acetazolamide or weight loss drugs and other things. What kind of impact does that have on sleep apnea and outcomes? And then nowadays, machine learning is everywhere. So there are thoughts that maybe those techniques can be used to identify who is at higher risk, maybe, for cardiovascular outcomes. Is there a subpopulation of patients that we're missing in these trials, like the sleepy ones? And also, who benefits the most from treatment? Is the signal of potential harm of increased mortality in some patient groups? Is that, who are these patients, right? Is it a subgroup? Is it a big group? Are there some people that we might be doing harm to by treating them? Or do really most people benefit from CPAP use? So here's the brief overview, what we talked about in the last 45 minutes. We do care because cardiovascular disease is so common and sleep apnea might be a modifiable risk factor for that. There's lots of data to show how the two might be related. The sympathetic nervous system activation that I showed earlier, the mechanical stress that we talked about when we talked about atrial fibrillation and how the heart is stretched and normal tissue replaced with scar tissue. Inflammation, I talked about that study that showed inflammation in the carotids and the alveoli. All of these things can lead to cardiovascular disease, right? We saw that there's a very high prevalence of sleep apnea and hypertension and atrial fibrillation. PAP treatment seems to reduce blood pressure and maybe atrial fibrillation recurrence. Definitely true in observational studies, randomized control trials. Maybe the definite answer is still lacking. And then does treatment prevent cardiovascular complications? Yeah, I just mentioned that several studies, observational studies have suggested a benefit, but the randomized control trials have the limitations that I discussed. And with that, I conclude and be interested to hear your questions or your thoughts on the Advent trial.
Thanks, Sonia. That was great, as always. If you don't mind stopping sharing, and if people can turn on their cameras for QA, that would be great. And I see something from Ron Chervin in the chat. Can you read his comment in the chat there?
For me, I have to just move my screen around again. Do you or Agrawal think that when sleep apnea occurs with HFpEF, the OSA is likely contributing to the HFpEF, whereas CSA occurs with HFrEF, the CSA is a result of HFrEF? I think that's very plausible, yes. Yeah. Meaning that in HFrEF, so heart failure with reduced ejection fraction, central sleep apnea might be a compensatory mechanism, might be a consequence of the heart disease rather than the other way around. And that in HFpEF, like we've seen earlier, they look a lot more like our typical sleep apnea patients, more likely to be overweight, more likely to be sleepy, more likely to be snoring. There it might be the other way around, where sleep apnea could have a better, more of an impact on heart function, and not be the consequence of the heart failure. I think that's personally, I think that's very likely, but it's not being studied much, in part because heart failure was always lumped together as one, and sleep apnea was also often lumped together in one. So I think in the future we've seen the trials that treat central sleep apnea and heart failure and HFrEF, but maybe eventually we'll see obstructive sleep apnea trials in HFpEF, and the results might be different.
A lot of work to do in this area,
Yeah,
hopefully by you.
hopefully, maybe right. Only somebody pays me to do it.
Anyway, well,
Yeah.
fantastic presentation. Thank you.
Thanks. I think Neeraj, you have your hand up, your virtual hand up.
Thank you, Sonia. Great talk. I think I always kind of walk away learning new every year with your presentations. Thank you. I just trying to see if somebody does the randomized controlled trials, I just want to get your thoughts on how would one kind of recruit, because the medications that are impacting the cardiac morbidities are getting much more advanced, and it's going to be hard to do a positive trial with any kind of intervention as it relates to sleep. How would you think about doing something on those lines? And I'm just curious on what are the challenges as researchers you will have to walk through that?
I think the challenges are enormous. I don't think I have a great answer, in part because of the sample size needed, right? I think even a relatively small effect would be of interest to these patients, right? Especially heart failure, where so many die within 5 years of, treatment prolongs their life even by a little bit, and quality of life that would be of interest to the patient and to the medical community. But the sample sizes are so large, needed. Adherence need to be good to treatment. And like you mentioned, all these confounders, including medications that are coming out all the time, and what impact do they have? We think that some of them might actually have a direct impact on sleep apnea severity potentially too, right? I don't know that I have a good answer. I think the field, the NIH or the field in general, is probably moving towards more secondary analysis of existing data, and in order to maximize the amount of data that can go in there and the number of patients and the complexity of the data, more and more machine learning is used in that area. I think we will see a lot of studies coming out in the next couple of years that use these techniques and try to circumvent the problem of needing to recruit hundreds or even thousands of patients and get them to use their CPAP. I don't know that that's a perfect solution, but maybe a multi-prong approach would work here too, where, in addition to machine learning, in addition to clinical trials, and maybe in addition to smaller trials of well-characterized patients, with really careful attention to their adherence, that could hopefully give us some answers to some of these unclear areas.
I had a question in
Go ahead.
regard to the beginning portion of the presentation, especially with the studies dealing with AFib. So if you have a patient you're evaluating that has no sleepiness, but has a history of AFib, would you order, would you want to rule out OSA even if they didn't have any daytime sleepiness, snoring? Would AFib be sufficient to for you to order that baseline PSG? Because I see that a lot from cardiology. They just like to, okay, patient has AFib, let's just order the PSG.
Yeah.
But based off that one study you were showing, and I had a conversation with Dr. Acho yesterday about this as well, it seems to be like, okay, if the patient's not having any symptoms, do we really need to order? Do we really need to rule out OSA?
Yeah, I think that's a really good question, right? A lot of the data that shows a benefit is observational. So in there, you have probably a lot of patients that were referred based on symptoms initially, right? The randomized controlled studies, they often rule out symptomatic patients, right? They don't include them because they're worried it's not ethical to randomize symptomatic patients because you could be improving their symptoms of daytime sleepiness, right? And therefore, then you have a limited randomized controlled trials of asymptomatic patients and you don't see a benefit, maybe because they're asymptomatic, maybe because they're not using their CPAP. So I don't think science has a definite answer to that issue, but I see the conundrum, right? Yeah, it becomes a little bit of a question of how much weight do you put on these observational studies, right? That probably included some asymptomatic patients, as opposed to the other ones. But yeah, I don't think there's a clear right or wrong answer. Unfortunately, that will make things easier.
Yeah, thank you.
All right, I think we're a little bit over time, but happy to answer, to stay on the call if people want to talk more, or answer questions later on.
I don't see any other hands up, but that was fabulous as always. Thank you.
All right, thank you all.